So, maybe you can tell me a little bit about what the difference between somatic and germline is, and then also maybe just what is next generation sequencing?
Yeah, so a lot of people don't like the term next generation sequencing. You'll hear it called like second generation sequencing, and there's potentially third and fourth generation
Yeah.
sequencing. So some people
Good point.
like the term actually massively parallel sequencing. So I mean it's really just taking, because you can do DNA or an RNA, but mainly DNA and making a fragment of what you're going to sequence, but many millions of fragments, and so that's why it's the massive amplification, and it really it has the power that you're able, compared to traditional Sanger sequencing, you can sequence millions of reactions at the same time, and so you can sequence with some of the commercial assays. I mean, most people aren't doing necessarily the entire exome or the genome, or there obviously are some companies that do that, but a targeted panel where you can look at like 320 genes or things like that on MSK Impact or Foundation Medicine, and as this the cost of this has decreased, and then companies like Foundation have gotten FDA approval for a lot of the advanced cancers. We're seeing more and more of it being used routinely. And so the important things to know, I guess, with the somatic is that's really done on the tumor, and so most of these companies, when they're sequencing the tumor, it's from an FFPE block, and so if it's ever insufficient, it's typically due because there's not enough tumor in the block compared to background lymphocytes or a stromal tissue. But you'll see a cutoff typically of about 20% for that type of sequencing, to make sure you're actually sequencing the tumor, which uses the somatic, as opposed to what would be in the germline. And with most germline testing for solid tumors, that's typically going to be performed on blood. And where it's really becoming useful is you're seeing a lot of treatments that are not necessarily as much derived from tissue of origin, but underlying molecular alteration. So with the treatment with the BRCA1 and BRCA2, obviously those aren't the only genes involved in the homologous recombination repair. So you have other genes like PALB2 and RAD51. And things like that, but that could be targeted with similar therapies potentially. But there's many other with these larger panel sequencing where you're not necessarily even exome, but where you're looking at 320 genes. You can pick up a lot of other things. So if the patient didn't have mismatch repair testing, you can actually see that signature that we do see more, the microsatellite instability that we see more often in the endometrial or the colon cancers. But there obviously are certain percentages of cancers that have that, and then there's other even driver alterations in specific genes that are seen much less frequently in Malarian origin, but there are trials with like the NCI match where patients could match on therapy with that, and other rearrangements that we typically think about in lung adenocarcinoma, where RET rearrangements or FGFR rearrangements. So it kind of opens the box to potential treatment options.
But I think it's really important, right? Because what we're talking about occurrences is as low as 1% to 2%, but very impactful on treatment. And even in the mismatched repair protein, it's most commonly quoted in the serous cancer. But if you look at the occurrence in mucinous in clear cell, it's actually quite in endometrioid. Excuse me, I almost forgot that. You're getting up there to numbers that are not that uncommon.
Right. So let me ask you, if you had your choice of the primary specimen, because you had primary debulking, or this biopsy that you took at recurrence, which one would you send?
If I took a biopsy at recurrence and there was adequate tissue to do what I call extended, next generation sequencing, massively parallel generation sequencing. If it was adequate, which it often is not, I would send the recurrence, but we usually send the primary.
Yeah. Jen?
Yeah, same. I think there's very little data to say whether there's much difference. I mean, there's data to say that within the same tumor there's difference
Right.
in different tumor types, but I don't think when the small retrospective studies that have looked at primary sequencing versus sequencing of the recurrence haven't shown much change or much difference.
Yeah,
And
we've
so
seen a fair amount of consistency.
yeah. But there's something about if you've like you said, Dave. I mean, there's something about you've got something that you just took the biopsy. It's the most recent tumor.
Yeah.
It makes sense to study that if you can.
I know in Ariel 2, when we were looking at rucaparib, we were looking at fresh and original tissue or historical archival tissue, and found that it was actually pretty close. wasn't very far off. I think the kind of the issue that comes up as we go forward is, are there new mutations that happen, or is it become more informative, and it's expensive? And so, where do you, how much, and ovarian cancer, frankly, doesn't have a lot of mutations, and it's a lot of copy number alteration problems that we don't have drugs for.
So some of this is going to go away a little bit with circulating DNA,
Yeah,
right? I mean,
yeah.
we're going to have some of that. We're going to be able to do this multiple times potentially. But I think where it really is impactful is when we're talking about the PARP inhibitors have they undergone a reversion mutation? And that would be one reason that I would use the
Yeah.
recurrent tissue.